welcome. On behalf of Heidi Waldron and myself, I'm Megan Anakin. I'd like to welcome you to today's session. As we begin today, on behalf of AIPPEN and ANZIPPE, I'd like to acknowledge and pay respect to the traditional owners, custodians, and knowledge holders of the lands and waters across Australia on which our members live and work, and to the elders past, present, and future. AIPPEN and ANZIPPE also acknowledge Māori as Tangata Whenua and Te Tiriti o Waitangi partners in Aotearoa, New Zealand. I invite you to introduce yourself and make any acknowledgements you feel are appropriate using the chat function of Zoom. Please ensure your first and last name are visible on your video tile. And if there are more than one of you joining from one device, please put both your names so we can make sure that we include you both, or three. Hopefully there's not more than one person per tile. And as I said, for those of you who are the on-time arrivers, if you're an AIPPEN member, please put IPE after your name, just so we can identify your allegiance a little bit. And if you're an ANZIPPE member, please put ANZ. And if you're a member of both, you can put both if you want, but it will just help us make a really nice mixture of people in the breakout rooms, which will be happening in about 15 to 20 minutes from now. This event is being recorded, so if you do not feel comfortable having your video on for this portion of the session, please, you can feel free to turn it off. But during the breakout rooms, please make sure your video does work. We don't record anything that happens in the breakout rooms. You're encouraged to use chat to share comments and ask questions throughout today's session. These networking events aim to spark conversations among those interested in interprofessional education and encourage the exchange of ideas and practices. And every time I come, I meet 5 or 6 new AIPPEN or ANZIPPE members that I didn't know before. So it's a great opportunity to enlarge your network across Australia, New Zealand, and sometimes we get people from elsewhere. I'm going to introduce our guest presenter today, Christie van Diggele. I'm going to invite you to draw on your own experiences that foster meaningful connections and insights. Today, Christie is going to talk about driving IPE success, building social capital among faculty. Now, this wasn't done on purpose. Yes, you know, I'm at the University of Sydney. Christie is also at the University of Sydney, but she was selected by Heidi and I without looking at affiliations. So I don't want to let you think there's a bias here. But she's now at the University of Sydney School of Business. Prior to this, she worked as the interprofessional learning lead in the Faculty of Medicine and Health here at the University of Sydney. In 2024, last year, Christie received a PhD for her thesis titled Integrating Interprofessional Learning into Curricula. So Christie is going to share a little bit of the findings from the interviews with faculty following the introduction of a new interprofessional learning curriculum at the University of Sydney. And she used the lens of social capital theory. She's going to encourage us to discuss ways to collectively shape a positive attitude towards interprofessional education within our own organizations and build on existing strengths. So we anticipate that you'll leave with at least one new idea, maybe a new colleague to share and explore ideas with. Over to you, Christie, please.
Thank you, Megan, and to the organising group today. It's exciting to share this work, and I feel a bit sad to be at the business school in some ways because I do miss the IPE space and working with colleagues in health professions education. So to give you a little bit of background to the Sydney context, there was a big faculty merge happening in around 2018, if I've got my years correct, which meant that we were getting more and more health professions working together in one shared space. So the Susan Wakehill Health Building was that space. And this coincided with the development of the new IPE strategy and curriculum. So we were very ambitious in what we wanted to achieve. We wanted to have this new strategy. We wanted to have all the disciplines involved, or as many as we could. and roll out an embedded curriculum to 10,000 students across 7 schools. So far we're at 6 schools, and hopefully it's expanding to public health as well. And we're reaching just over 5,000 health professional students each year. We took on board a 3-phase approach, which many of you have in place. So we're starting off with that introductory knowledge or building a bit of theory into our learning, moving into a simulated experiences, whether that's case-based work or whether it's in the brand new sim labs, and then moving on to those clinical placement sites or the community placement sites that our students visit. We also introduced an e-passport, so we're tracking all of students' progress through these programs. And we wanted our activities to be scalable. So we had a lot of boutique activities happening throughout the university, but we wanted a centralized approach and ones that we could, where we could include more students, and also just to give them more exposure to their health professional colleagues ready for the workforce. Some of the activities are still around that number of 42 students, and some of those are opt-in. And then our large-scale ones were embedded with assessment tasks associated, so they were hurdle tasks within units of study. And we were evaluating a lot of these programs, sorry, just going to the next slide, but we weren't quite formally looking at what staff were thinking. So we'd get some feedback in our advisory group or community of practice, but we wanted to do a little bit of research in this space to see what staff perceptions were in relation to this newly embedded curriculum. We wanted to see what the enablers and barriers were as well, so that we could implement some further changes to improve what we were doing. So as Megan said, we invited faculty to come along for interviews to get some feedback on this and then hopefully implement some changes. So the framework that we used was social capital theory. And the reason it was chosen was because of that social interaction or interactive side of IPE. So we thought it was a really good fit. Lee and colleagues had also published an article where they suggested that social capital theory could be used to identify, understand, and overcome barriers to IPE. And as you know, there are always barriers. So we wanted to identify these early on and see where we could make some further improvements. There were 3 dimensions for this, and although they interrelate and interconnect with each other, we did try to separate them in our study. So structural was looking at the communication side, the roles, values, procedures that were in place, so kind of the faculty structure, as well as trust and the expectations of staff within the faculty too. And then cognitive, we looked at one of the main parts that we found here were misunderstandings or misconceptions, which I will go into, and it forms part of our discussion today. But it also looks at the shared goals and values of the organisation. So obviously with the curriculum being new, we wanted to kind of work in this space to have a shared understanding of what was happening. And then relational is the trustworthiness and reliability of individuals, as well as the leadership opportunities and reward and recognition for staff that were taking part in these activities. So what did we find out? So we really found that faculty appreciated the centralised coordination of the IPE curriculum, that it was being managed by a team that were coordinating the timetabling, the assessment tasks, Canvas sites, all of those logistical components that can be quite complicated. And they really valued the IPE champions. So we had champions distributed within each of the schools or disciplines to feed or relay information coming from the advisory group and community of practice. And also to relay information from those schools back to the centralised team. So some of the things we found were that the faculty was improving. They looked forward to more interdisciplinary action or interaction between staff. So as I mentioned earlier, this was coinciding with a shared space for people to work in. So there was more informal discussion happening even in kitchen areas once this was in place. The communication and working with staff seemed to be very well organised, and that they wanted everybody to be involved. We had this common theme coming through that it was everybody's business. So how do we get more junior staff and senior staff involved in IPE as well? However, we did find that staff were feeling a bit fatigued. So, as you probably find in your own workplace, it's usually the same people. So, it's the same faces coming along. They're putting in a lot more effort. So, they really wanted to distribute this workload a little bit more and get others on board with IPE because it is so fantastic and they could see the value in it. So, as I mentioned earlier, with that cognitive kind of dimension, there were still some misconceptions, or I probably should use the word misunderstandings. So, although we had this marketing plan in place with the marketing communications team, we thought we were very well prepared. They said there could be more marketing. So, we had social media, we had newsletter items, we had all sorts of things happening. However, we were missing the mark somewhere. We also had feedback that the curriculum wasn't embedded. So some staff were unaware of it sitting within units of study and still thought that it was an add-on activity. And that we could do more across the disciplines. So although we were reaching in some cases 2,500 students with 13 health disciplines involved, some staff still felt that we could reach more disciplines, and perhaps that was in relation to those boutique activities where more specific disciplines were being targeted. And so this leads me to our discussion points. So today I thought in the breakout rooms, we could discuss maybe some of the common misconceptions or misunderstandings that you have with your students or your staff, more likely, and how to reduce these. And how can we pitch IPL to colleagues briefly and effectively to inform them and bring them on board? So feedback from our staff was that they wanted more junior staff on board or early career academics. So what can we do to bring them on board and have them contributing to IPE and seeing the value in what we do? And I'll hand over to you, Megan.
Thanks, Christie. In just a moment, you'll be invited to join a breakout room to discuss the two prompts that Christie has outlined for us. You will have either Christie, if you're the lucky room, or equally wonderful, one of the AIPPEN steering committee members or an ANZIPPE fellow in the room with you to ensure that you have a rich discussion. They're there to facilitate the discussion for you. Now, please, before you jump into these two prompts for discussion, please take a moment to introduce yourself to each other by at least stating your name so we pronounce it correctly, where you work, and your interest or experience in IPE, because I think that will really help people understand what you talk about when you talk about the challenges and the ideas. Here we go. I think we're ready, Kendall.
Due to a Zoom technicality, we unfortunately do not have the recording of the second half of our session after the breakout rooms. So I'm going to summarize what was discussed from each of the breakout rooms. Heidi Waldron, who was in room 6, said misconceptions and misunderstandings. Not every health professional sees the need for IPL, even when it seems obvious to most. Faculty support and accreditation, great support and drivers. Clinicians buy-in can be challenging, partly because of worry that it diminishes clinical placement hours, for example, nursing students. But this concern is shared by both staff and students. 2, that staff work commitments if doing shift work. 3, that preconceived views of disciplines such as medicine being a certain way, stereotypes. IPL offer ways of introducing students to disciplines in a positive way. Often ratios of students to staff is disproportionate. Example, nursing have 750 students and 2 staff champions. So how to share the load often needs a very long lead in so that staff can timetable a year of staff. Megan Anakin, who was in room 5, said that some of the misconceptions are that certain professions should be leading IPE, but only certain professions should be involved. Focus on doctors and nurses, and not understanding other professions work together. So not being clear on the role of each health professional. IPE is viewed as very second class, so not as important as other skills and knowledge. How can we pitch it to our colleagues? Megan and room 5 Said bringing students on board in their first year normalises the experience and can help persuade colleagues with their enthusiasm, show the outcomes and advantages of IPE to the colleagues, acknowledge that not everyone will feel comfortable teaching students outside of their profession. The workload allocation might recruit academics as facilitators and teachers who are there for the wrong reasons. A faculty approach to involving staff as a core activity and inviting colleagues to come along and co-facilitate by watching the first time and taking on leading one activity the next time. Philip Priory was facilitating room 4. Philippa's group said that there are parallels with cultural safety. There's misconceptions that depend on the experiences and understanding of the individual. As educators, we can sometimes make assumptions about what people know. Teaching style is different in IPL and can be overwhelming. Sometimes it's seen as not as important as the discipline-specific skills. And then how to sell it. It's fun. It's a level of richness that is not understood. So many new opportunities come out of this. It might take time at the start, but it pays off over time. It creates research collaborations. It's real life. And be smart about who to engage with and why, and to share your message about bringing people along. Who do we need to put energy into promoting IPL? People who are new and include into orientation. We need champions and designated roles. Hannah Olsen, who's in room 1. Room 1 said that having trust with academic leaders, trying to protect students. Elements of trust need to be embedded, maintaining conversations and keeping an open dialogue. Krista Reid and room 2 discussed the need to educate staff on what IPE is and what IPE is not, interdisciplinary versus multidisciplinary. We discussed the need to create IPL with interdisciplinary teams, including education designers. We discussed some common barriers such as workloads and being remote. Christie van Diggele and room 3, their group discussed faculty and student bias and stereotypes that may exist between disciplines and whether they do exist or if it's a misconception or a misunderstanding. They also spoke about how they can work to reduce bias and stereotypes through exposure to IPE and role modelling appropriate behaviour as faculty. They also discussed the definition of IPE and associated misconceptions. The people in that group were at the very early stages of implementing an IPE curriculum, so they discussed ways to get started and shared resources. We have some upcoming events. On the 21st of August, we have a How Do I Develop Professional Capabilities in Future Healthcare Professionals with Virtual Simulation session. And on the 18th of September, we have a How Do I Write for Publication in FOPE session, both PD sessions. Huge news coming out of FOPE. We're very excited to share that FOPE now has a journal impact factor of 3 and ranks number 21, which is a Q1 journal. This is the feedback survey link, and it will be shared with you in your recording email. Thank you very much for joining us.